Welcome back to the Global Gratitude Summit. I'm Luann Saraga Walters. What an amazing and tender and necessary and touching episode that we have for you today. Dr. Jessica Zitter is our guest expert. She's a medical doctor who practices ICU and palliative care at the County Hospital in Oakland, California. She's the author of Extreme Measures, Finding a Better Path at the End of Life. Her essays and articles have appeared in the New York Times, The Atlantic, The Huffington Post, the Journal of the American Medical Association, and other publications. Her work is featured in the Oscar and Emmy-nominated short documentary Extremis, which is fantastic, now streaming on Netflix. She's a nationally recognized speaker on the topic of dying in America, and though it's not an easy topic, it is a necessary one. We're honored to have Dr. Zitter join us today to take a thoughtful and compassionate view of how gratitude can help change the way that we approach and treat death and dying. And I should say, Dr. Jessica Zitter, thank you for joining us.
Thank you for having me. Thank you so much.
You've really taken on a very large subject matter and one that people want to shy away from. We wanted to include this in the Global Gratitude Summit because we can't escape death, and it's something that's so pertinent to all of us. It's something that I personally experienced 6 years ago, and I want to start off by saying thank you for doing what you're doing. But let's start where we are, Dr. Zitter. How did you even come to this? What prompted you out of medical school to A, take on ICU and palliative care, and then B, to really focus on changing the way we experience death and dying in America?
Well, it's an interesting story. It didn't start out as a focus on palliative care. I actually went the other direction and was all about not really talking much and maximizing treatment. Just treat people with whatever we have, whatever technology, whatever medications, anything possible, throw it at the situation to find any potential for life prolongation. And I came from a family of a lot of surgeons and emergency room physicians, and there was this sort of sense that that's what medicine was all about, was just try to save life. And almost in this fantasy-based way, I realized as I look back on it. And I really, over the first several years of my practice, and even during my residency training, I started to realize that I was actually frequently, it was subconscious, and it was really just percolating moral distress, but I was sort of having this sense that a lot of times the activities and the actions that I was doing that I'd been trained to do were actually causing more harm and suffering than benefit. And more importantly, I hadn't even asked permission. It was just an assumption that this is the way it was supposed to be, and this is what people would want. And I started to understand that that wasn't necessarily what people wanted. And then I was found about 10 years into my training by the palliative care movement by complete and utter luck. It wasn't, I happened to be at a hospital practicing my ICU medicine that had won and this was in 2003, before the palliative care movement really became an official medical movement and medical subspecialty. And I was in a place where they had won this very unique grant from the Robert Wood Johnson Foundation to do communication, essentially the forerunner of palliative care, to enhance communication in the intensive care unit. And I really thought, well, I'm not really sure who these people are here in our intensive care unit, but all of a sudden was surrounded by people kind of helping me understand that I was actually doing things without really communicating. And I was actually not attending to some of the very important humanistic pieces of that people need when they're sick. And it took me a lot of time and honestly shedding a lot of barriers and images, self-image, to start to open up to a new way of doing things. And that's how I found the palliative care movement in 2003, 2004.
You talk about in your book, Extreme Measures, you talk about there's a little bit of a conflict at times between ICU care and palliative care. And can you explain that a little bit? Because I think that we assume that they may be one and the same, and palliative care is kind of just like hospice, may be end of life, may not be, but everything is always trying to. So walk us through that. Yeah. Because I thought that was really an interesting distinction.
Well, here, let me give you the punchline. The punchline is that they're actually not in any way at odds. They are completely to be married together. in perpetuity, such as also as is cardiology and palliative care, and is oncology and palliative care. In an ideal world, the principles of palliative care medicine would be really incorporated into every single type of subspecialty medicine. And we're not doing that at all. We're not even close to doing that. What is palliative care? It's the palliation, actually is a Latin word meaning to cloak people in their suffering, to care for people in their suffering. And by the way, when people have serious illness, certainly when they're dying, but even if they aren't dying, there's all sorts of suffering that occurs that we haven't, in traditional medical world and culture, we don't even think about. Of course, there's physical pain, suffering, nausea, etc. But there's also the suffering of a change in social status, the incredible emotional suffering of uncertainty and fear and existential crises around death. So there's a spiritual crises, which are huge in thing to think about when somebody is really approaching the end of his or her life. So to palliate somebody should not be something unique to one subspecialty of medicine. This should be something that is completely woven into all aspects and all facets of medical care. And it's not. And so, there's no, in theory, there's no reason why palliative care and ICU care should be even considered at odds. They should be married and hand in hand. But the fact is that culturally, they are considered to be at odds, because the way people think about the subspecialties, ICU as one of them, which is all about, or has been traditionally, just the pure brute force of keeping a body alive, keeping a heart pumping, mm-hmm. That kind of doesn't necessarily psychologically make sense when you put it in hand with the idea of stopping, reassessing, considering, weighing benefits and burdens, and making decisions not just based on brute force, but actually on patient values and preferences and the reality of their prognosis. So there was a lot of resistance when I went, sort of from this ICU world into this world of thinking about more from the patient-centered. And frankly, I'd have to say most of the resistance intermittently comes from me. So I've, been through a culture crisis. It's a hard thing to change your entire philosophy of who you are and what you're there for as a doctor.
Do you mean professionally or personally, that resistance?
Both. I think both. I would tell you that I have so many moments where I feel I've incorporated this feeling of failure if I am not able to correct medical illness or disease. Let me just close this window, sorry. That is what the subspecialty of intensive care, although hopefully is starting to change, it's all, what is considered success is physiologic success, prolongation of life. That's success. And so the idea of success as being changing, enhancing comfort, managing quality of life, that's still a hard thing. It's a hard thing to swallow, even though cognitively I know it's true that that's success. Finding other definitions of success takes work when you've been trained so intensely in one way.
You're speaking actually to an experience that I had with when my mother was in ICU 6 years ago. She went in and out of ICU 3 times before the last time. And each time my sister and I were, rallying around, she's coming home. She's coming home. And she looked like she would for a couple of times, and that didn't happen. But I know there was one time, and when you say breaking through your own resistance, I was resisting acknowledging what was happening. And I think that's where we're kind of shifting into that gratitude portion, because there's the reality of ICU, there's the reality of death, there's the reality of dying that we don't necessarily want to experience or face. My mother had asked me to be able to speak with her about her last wishes. And my response was, Mom, we don't need to talk about that. You're going to be fine. You're going to be fine. But listening to you, reading this book, and also seeing Extremis really emphasized the experience that I had with one of her ICU doctors who had pulled me aside and said, your mother asked me to talk with you. It's important to her that she's able to communicate with you what her last wishes are. That doesn't mean that she's going to die, but she needs to be able to speak that. And that was a big lesson, because that was an opportunity for me to step into well, my blessing of being able to be there for her in that moment. So
Wow.
the resistance that we face, it's profound. And the fact that you're able to address it both professionally and personally as a human being, that's challenging, Dr. Newdick-Zitter. That's a hard thing to do. How do you work with your patients through that? The patients who are dying and also their family members.
It's complicated, and it takes constant correction and a certain type of cognitive, reprocessing all the time, like almost a mindfulness of saying, okay, I'm having this response. Let me bring myself back into this moment and understand it from a higher level. And it's hard. And, as you do it more and more, you become more comfortable with it. What's interesting to me about what you just told me is you were obviously a loving, caring daughter. You were trying to do your idea of successful daughtering, which is to say, Mom, we're not going there. You're going to be okay. We're going to get you home. And then what you had was a correction. Your mother said, hey, wait a minute. I need this from you.
Right.
And you heard that through the nurse, and you corrected yourself, and you reframed what success as a daughter, what being a successful daughter was. Mm-hmm. And it's so interesting because that, I think, is what I'm continuously trying to do as a doctor. And by the way, it's not just my own internal thing. I mean, there's a lot of out there in medical culture that really still needs to be fixed, telling you what is being a good doctor, and of course for you, what is being a good daughter? You learned a new way, but it takes a lot of continued work. Medical culture is a very powerful thing. You have Grey's Anatomy. It's not just the doctors that are part of this. It's what is expected from the lay community. They're watching Grey's Anatomy. They want a doctor like Dr. McDreamy. And there's plenty of data that shows, that patients don't like doctors who give bad news as much as they like doctors who give good news. So the fact is, we've all got to reframe, hopefully, what is a good daughter? What is a good doctor? And start to think in slightly different ways based more on the reality of what happens on what I call the end-of-life conveyor belt.
So how do you, okay, 3 different ways I want to ask you this question. How do you communicate to your residents, to your patients, and to the family members of those patients, how to find the grace, the blessings, the gratitude in acknowledging that end of life stage? You're in the position that you have to cut through all of that in order to be able to have that real experience for that dying patient. So how do you begin to do that? And I guess I kind of want you to start with the patient, because I think that's really the focal point, and then maybe back out with family and physician a little bit to see what that looks like.
It's so interesting, when there is this sort of mechanism of fantasy, this whole industry of fantasy. I mean, you watch CNN, you go between 2 commercial breaks, you're going to find, how many advertisements for miracle drugs and different cancer drugs and the Cancer Center Cancer Center of America, and we're going to save you. And when I got diagnosed with breast cancer, I called them, and now I'm fine. I'm going to fight. You are working against a whole culture of life affirming. Life affirming isn't the right, but beating death. That's sort of a whole industry of beating death. And of course, we know that we have 100% prevalence of death. Every single one of us is going to die. And so, and by the way, by the time I get to them, they're usually dying, because a lot of the patients who, by the time they come into an intensive care unit, really are so sick, or by the time they see, a palliative care doctor for intractable symptoms, they're really so sick. And so you're trying to undo this whole lifetime of fantasy, that we're going to evade death, so we're going to at least be able to kick it down the road. And so when I go in and I have bad news, and this is what we in the palliative care movement really practice day in and day out, and it's hard stuff. I just gave a lecture today to these residents talking about all the different variables that are going to be in the room with you when you're trying to break bad news to somebody. All the personal human variables, the fear, the anxiety, the guilt, not only by the way of the patient and family, but the sister who has to make a decision about whether or not to withdraw the ventilator. These kinds of factors are so powerful, and you have to learn communication skills, because these are the most difficult conversations of all. This is the most difficult news of all, to bring to somebody, that they or their loved one is dying. And it requires skill and practice and experience. And even with all of that, it doesn't always go well. And we in the medical community are working to try to increase that skill level in our practitioners. I'm part of a group called Vital Talk, which is very exciting, skill-based program to enhance communication skills for clinicians, whether they be social workers, physicians, nurses, etc. I'm one of the faculty trainers for them, and we're doing a lot of exciting stuff, especially here in the Bay Area. And I cannot stress enough how important it is that we start to train our clinicians, whether they be palliative care doctors or whether they be cardiologists, oncologists, nurses, nutritionists. I don't care who you are. You've got to start to learn some basic communication skills, which we have been ignoring and not treating as important. They're not things that we care about that much. We've got to start treating them, teaching people with brute memorization of how are you going to deal with this situation? How are you going to deal with that situation? What are you going to do if this happens? What are some phrases that you can use to temper the emotion in the room right now? Because let me tell you, one of the biggest challenges is the emotion.
I bet.
You, as a clinician with bad news to break, cannot stand with somebody as they're having emotion, and a lot of it directed at you, possibly a negative or crying. We have to first and foremost be able to manage the emotion in the room, and it's really hard.
So I want to pause you on that, because I think this is a key part in this summit. Of you're talking about an intention, an intention of walking into a room with a certain mindset, a mindfulness, a behavior. What can you share? What you do? Do you have a certain aspect that reminds you that I am working for this patient? Is there some area of gratitude or grace that you can cling into when you walk into that room to have that conversation with the patient and the family?
Yes. And I'll tell you that what it all comes down to really deeply is seeing that person as a human being. I know that sounds trite, and it sounds nebulous, and well, what does that mean? But it's actually really simple. And it's something that I learn all the time. I mean, I'm still learning this, and I've been practicing for a long time, but it's about remembering that the person in the bed is a person who has feelings and who has a history and who has fears, and who could be you, and to connect to a person on that level of who they are and what's important to them. And forget making decisions and do you want me to code you or not code you, or do you want me to use the ventilator? That stuff is secondary. That stuff flows from the relationship. And it's all about the relationship. And when you ask me, talk to me about gratitude and how does gratitude help you in your work and how could it help patients who are going through these challenges? I mentioned to you Chaplain Betty Clark, who is the chaplain that I've been working with now for 10 years. She's an African-American woman who came from hard circumstances in Kentucky, and who, she jokes, she's lived 9 lives. She's had physical complications. She's just, exposed to lots of arsenic, as she worked in the tobacco fields in Kentucky and as a sharecropper, etc. And she's just really, she jokes, 9 lives. She really has just gone through so much. And she's this incredible woman. And I watch her with patients, and I listen to her when she talks to me about how I was with the patient. And what I've learned from her is how to really see people as people. And I still have my moments where I lapse and I kind of get into the kidneys and, but the most important thing in that room is the person and the relationship. And then all the other decisions and all of the other information flows from that. So I don't know, that's a long-winded answer to your question. But
no, you were going right into it, which I think is wonderful, because you're kind of stepping into Well, there's a lot of different hats that you're wearing with that, because that human to human connection is, it's vital to understand what they're wanting, how you can communicate that with them, how you can touch the family without off-putting them, or even bad news I can see what you mean. It can be threatening to the family that you're not on their side, or, you're not doing all you can. We need a better doctor. Those kinds of things can all come at you. So you're really having to step into a heart space of, I need to connect with this human being. That's my first and foremost. And I think that's vital. Is that something that you just discovered on your own, or is there a class for that in medical school? I'm saying that a little facetious. I mean, there may be, who knows? There may be, I don't know.
I don't think there is, that I know of yet, a class about that. I mean, we have our 10 hours, and when I was in medical school, I learned 10 hours of, cultural sensitivity training and learning about, Chinese culture and African. Ultimately, there are as many different types of Chinese people as there are women. And there are as many different types of, Koreans. I mean, you cannot group people that way, because what it really comes down to is so many variables that are interacting to be part of the relationship between you and that person in that room. For example, what was the last doctor who was in there, how did they respond to that person? And if there's distrust there, it's going to impact the way they feel about you. There's too many variables involved to make huge generalizations. There's some basic things you need to understand in terms of cultural sensitivity, but really you need to get to know each person uniquely, and connect with them on some level. So there isn't really, I don't know that there's actually a class. I think it's really based on experience, and it's based, for me, on seeing what happens when I do connect with patients and when I don't connect with patients. And, I guess
what do you talk to your residents? How do you speak to your residents about that, about the lessons that you've learned? I mean, it may just be that. It may be, connect with the human being.
Well, we're just I'm going to tell you the honest truth about the palliative care movement and about educating educating about humanism in the hospital setting and in medical school. I don't personally, I'm not an educator officially, although I do a lot of teaching, but I really, in my own experience, we did not have a lot of training for this. And even today, there are some medical schools which may focus a little bit more on sort of seeing people for who they are. There may be some programs, for example, that think more about the social determinants of health, which are really critical, because a lot of my patients don't have a place to live, and that's going to, impact their experience very, very much compared to a patient who, or a group of patients who are, who have privilege and housing and et cetera. So I think what we haven't done very well is really taught our students how to see through all of the stress and the emotion and the physiology and the disease to the person. And I think it's not a classroom thing. I think it's a story thing. I know that narrative medicine, which is a new, reasonably over the past 10, 15 years, getting more and more play in medical schools, teaching through story, reading stories, getting people to read stories and kind of have an emotional connection. There's data that shows that it increases empathy towards patients. It's effective that way. I think narrative medicine is one very important type of class that people can start to gain connection to their patients through. And I think a lot of it just has to do with being exposed to teachers and walking around the wards with teachers and watching them do it. I learned mine from Betty. I'm going to be honest. I've learned a lot more about being a humanistic doctor from nurses and chaplains than I ever did from the medical community. Sorry, but it's true. So I think, the conversation's got to change, and we've just got to start. We got a lot of work to do.
Are you, have you, in the process of looking at how the American culture, and this being the Global Gratitude Summit, how the American culture views death and dying, and the work that we're doing towards transforming that a little bit, are you familiar with other countries, other cultures that might have some different viewpoints on it, that it would be great for us to be able to kind of get to, anything like that?
It's a really interesting question, because I think a lot of the problem of this sort of end of life conveyor belt, which is a concept that I talk about a lot in my book, this sort of sense of this relentlessly moving conveyor belt that doesn't really take any kind of human input. It's just, you're just kind of throwing things on this conveyor belt and throwing other machines on and just keeping the patient going. And there's not much conversation going on. Unfortunately, I do believe this is a pretty uniquely, it's not uniquely American, but it is a very American concept. And it has been exported, like so many things, to other countries. And also some of the good stuff we're doing in terms of management of suffering and palliative care is also being exported. But this idea of, just relentlessly heaping on technology and not necessarily talking about it, or not necessarily really having a realistic conversation about the benefits and the burdens and the true prognosis. It's part of this sort of pull yourself up by your bootstraps. We got to work hard. If we work hard, we can overcome. And that's a very American, God bless us, concept. And so other countries, in my book, I talk at one, I can't remember which chapter it is, but I tell a story about a Pakistani resident on my service. And we were going back and forth of, should we talk about, should we offer dialysis here? Does dialysis make sense? Should we do? And I said, so what do you think? I said to this resident. She kind of looked at me. She laughed. Do you really want to know what I think? And I said, yeah, I actually really do. And she said, in Pakistan, we wouldn't be having this conversation. She said, this is, this, she sort of said, you're this cogitating back and forth about, that this dialysis isn't going to help this person, but you think you should tell her about it. We don't think that it's medically going to be of benefit. It wouldn't be part of the conversation. It wouldn't be a thing they could choose or not choose. It just wouldn't be offered. And so I think that a lot of the mess we've gotten ourselves into in some ways has to do with this American love of autonomy, which I completely agree with, and I love autonomy too, but we've taken it to an extreme in the medical world where we're asking patients and family members to make decisions that they have no experience or really no place making. It's unfair to ask a layperson some of the questions we're asking them. What we really need to be asking is the bigger picture values and goals and needs and hopes and what's important to people. And then the decisions can flow from that. But we're not doing those more difficult steps first. We're just going directly to all of our different technologies and like a checkbox, like a kind of cafeteria plan. Well, do you want this? Do you want this? Do you want this? And I don't think that makes a lot of sense. And that's what we do here. And I think other countries don't do it as much.
And would you, so as a physician, I'm sure you do, recommend that people have these conversations as families now before anyone is sick? Have this conversation. What would you like?
Yes.
Well, that may change depending on the situation, but.
Well, the mantra of what we recommend as a palliative care community, as an advanced care planning community, is advanced care planning. This stuff shouldn't be happening in the intensive care unit at the 11th hour, these conversations. These are not good conversations to be happening in moments of physiologic and emotional extremes and fear. They're conversations that should be at least initiated and planned and talked about over years and years of good health with family members who will be caring for each other as life goes on. It is very, very hard for a family member to be left standing in a room with a dying loved one and being asked by their doctor, do you want us to do this or not? There should be some general sense of what this patient would have wanted in that particular condition that was attested to and talked about, so that they have some goals. Because there's a lot of what happens if you've never had that conversation. Nobody wants to pull the plug on grandma. Nobody wants to do that. And if you've never talked about it, you won't do it. And so we end up increasing the numbers in this rising prevalence of people who are living on machines until they die, which is a public health crisis of tremendous proportion. People living in facilities on machines, attached to machines until they die. It's distressing.
Which makes me again want to emphasize to everybody who's listening or watching, please go to Netflix streaming and watch Extremis. It's a fantastic short documentary, but it's very well done. You know, you're speaking to something that I think you're also kind of working on. And by the way, I have to give away a little bit of this, because when I found out that you had a choice between becoming a medical doctor or a rabbi, I think you've kind of fulfilled both, Dr.
Oh,
Nudix Zitter. You're very humanistic in your approach with everything that you're doing. So there you go. But you've also begun a new project that I know is the subject of another documentary that you're working on, and that is a curriculum for high school. Wow, on death and dying. Can you briefly talk about that as we are coming to the end of our session today?
well, I will quickly tell you that. And just so you know, Extremis is important to watch, but the appendix in my book gives you specific steps to how to actually make these plans and what should you do next. So it guides you through this process. So I hope.
Fabulous. And again, that's Extreme Measures, Finding a Better Path to the End of Life, which you can get out through Dr. Nudix Zitter's website, which is jessicazitter.com.
Thank you. Death Ed was an idea that came to a friend of mine, Dawn Gross, who's also a palliative care physician, and myself, both of whom have taught sex ed to our kids' classes in their high schools and their middle schools, and thought, well, wait a minute here, why sex ed and not death ed? I mean, death ed should be a kind of part of the curriculum, just like sex ed should. We know sex ed increases kids' physical and emotional health and well-being. I think death ed would do the same thing. And so we did that. And it's a really important piece. Please read my article in the New York Times called First Sex Ed, Then Death Ed. And it really gives you sort of a sense of how we did it.
That's amazing. That's wonderful. Yeah, I'm definitely going to be looking that up, and I'm sure that a lot of other people will too. So we have one final question, and that is, I know that we've been talking about it in a kind of tapestry interwoven fashion throughout this entire session, but what is your personal definition of gratitude, coming from where you are and what you're doing? How do you see gratitude?
Wow. The first thing I would tell you is it's so personal. What's great, what I would be grateful for is so different from what another person would be grateful for. What I would be grateful for today would be so different possibly from what I would be grateful for if I'm in a bed dying of metastatic breast cancer. I can't necessarily know what would be the things that would be most important to me in those moments. Right now, I think about gratitude a lot. I think about gratitude because my husband's a very, very grateful person. In fact, we just had his 60th birthday and jokingly, made some bags. I have a picture of him that says, what are you grateful for? Because he's always talking about gratitude, and has been actually a big, I'd say, an inspiration for me about thinking about what I'm grateful for. But it's the little things in life. It's the moments of connection. It's the moments where you feel healthy. It's the moments where your kid actually smiles at you and isn't cranky with you. It's the moments where your dog comes and puts her head on your lap and gives you a little yawn. I mean, there's so many little moments that just lift the spirit. And I think my hope is that for people who are dying, for my patients, my family, my friends, myself, in those moments when you most need strength and to feel grateful for something, that we work, those of us around those people, and work to find out what those little things are that are going to make somebody feel grateful in that moment and lift their spirit a little bit.
Beautiful. Thank you so much for being with us, Dr. Nudix Zitter, on the Global Gratitude Summit. Your work that you're doing is incredibly important. I wish that I had come to know you 6 years prior or 8 years prior, so that I could have been better prepared, I think, during the time that I had with my mother's own passing. But the work that you're doing is very heartfelt. It's life-changing. And it's something that we don't necessarily want to talk about, as we said, and yet you're doing it and you're going through it. And I can't thank you enough for it. I can't honestly thank you enough for everything that you're doing and leading. And I just wish you continued success with this. Thank you so much for being on the Global Gratitude Summit with us today.
Oh, thank you so much for having me, and you're inspiring to me, so it helps make me keep going on. I really appreciate it.
Thank you.